Okay, hello and welcome everybody, and thank you for joining this session today with Nottingham University Hospitals. We've kindly been joined by Sandra and Linda, who have also been joined by patient volunteers Trish and Michael to discuss the hard work that has been going on at Nottingham University Hospitals, focusing on co-producing a patient improvement strategy and plan. Now I'm going to hand right on over to the team who have got their own slides ready to go to start sharing and talking about their experiences. So I'll hand it straight over. Welcome.
Thanks, Anne. Hi, so I'm Linda Pitchford and I'm the Head of Transformation at Nottingham University Hospitals. And I'll just ask my colleagues Sandra and Trish and Michael just to say hello and introduce themselves, and then we'll go straight into our presentation.
Thank you, Linda. So my name is Sandra Minich. I work at Nottingham University Hospitals and I am a Senior Improvement Lead.
Hello, my name is Trish Cargill. I'm a volunteer patient representative and I'm part of the PPI Qi group at NUH.
Hi everyone, I'm Michael Pryor. I'm also a patient volunteer supporting the work that we're going to be talking about today. I've been involved in patient and public involvement work in a number of areas in the hospital and in the sort of research landscape in Nottingham as well. For about 10 years now. That was having had to retire early because of a lot of complex health effects arising from treatment I had when I was a graduate student in Oxford, where Hanan is now, and all of that lies right at the heart of my motivation for trying to put something back into healthcare and make healthcare better in the future. Thank you.
Thanks, everybody. Okay, I'm just going to share my screen. Okay, so as we said, we're from Nottingham University Hospitals and we are a large teaching hospital across 3 sites, and we provide services to 2.5 million residents of Nottingham and its surrounding communities. We're also a tertiary referral hospital, so a further 3 to 4 million people across our region access our specialist services. So we have specialist services in stroke, renal, neurosciences, cancer and trauma. And we have a long history of quality improvement at Nottingham, but have had an ambition to shift the balance of power, incorporating co-production as a default in all our QI work. And that is the kind of key message we want to get across on this presentation today about how did we shift the balance of power and what does that actually mean. Our quality improvement volunteers comprise of a team of 10 core members, and Trish and Michael are 2 of that core team, and 70% of our members have had QSA fundamentals training, so that's quality service improvement methodology training, and Michael and Trish have both been through that training. So what we wanted to start to talk through today was really what was the problem that we were trying to solve. Because as we said, we've got a long history at Nottingham University Hospitals of improvement, and we have had a long history of using insight and help us inform our quality improvement projects and what we would be concentrating on and putting our time into. But we realised in 2021, 22, just out on the back of COVID really, that there was lots of learning from the COVID pandemic in health and social care. And this included critical ingredients for change. And one of the recommendations, in fact, it was the number 1 recommendation that came out from a lot of the research and a lot of the learning from COVID, was that co-production as a default was something that we should all be considering in our improvement programs. So we did a gap analysis and we looked to find out where we thought we were as an organisation. And visually in front of you, you can see the kind of 3 steps. And we were in that middle step. We felt like that we weren't using co-production as a default, but we was very much into insight and feedback, and using that insight and feedback to inform our improvement projects. But we hadn't actually gone that 1 step further forward and really involved patients and carers in helping us design the solutions to the improvement work that we were doing, and standing shoulder to shoulder and really conceding that power. And what does that actually mean? Shifting that balance and working together as teams with staff and patients to really co-design our improvement programs. So one of the first things we did, really trying to answer the question, and the aim was to shift that balance of power, and we really wanted to move from you said we did, which is where we were at, to we said we did. And so we, as a result of that, we co-produced a NUH QI quality improvement strategy. The key messages within that strategy is really about co-production as a default. The strategy was sponsored by our senior leaders who really championed this approach, and it was underpinned with inclusive recruitment, taking positive steps to include underrepresented groups. Now, as we go further and forward in describing where we're at, that is one of the challenges that we still face, and it's one of the things that we would like to draw out a little bit more of the chat and conversations at the end. So looking to the audience really somewhat to help us to see how we can address that challenge. And we actively identify areas of work where co-production can have a genuine impact and involve patient volunteers and carers at the earlier stages of project design. I think one of the things that we were really reflective of when we did our gap analysis and really looked at what our PPI Qi approach was, is that often the decision had been made and the project designed and the aims articulated, and then we would go and ask for PPI representatives. And one of the shifts that is written into the strategy is that actually that should happen at the very earliest stages of any project design. And our objective is to build the co-production into our work programs as default. And at the end of this presentation, we'll talk to you about a wider program of work around the emergency pathway, where we really believe we're starting to do that. And train and develop staff and patient volunteers so that everyone understands what we mean by co-production, what it is and how we can make it happen. One of the things that we are in the process of designing at the moment is a PPI framework that does just that. So it's a how-to guide that staff and patients can go to really understand the how. So we talked about senior leadership being involved and advocacy and sponsorship. And actually, this is where we really start to shift the culture. So with the conversations that we've had with our board and with our wider leaders and staff across the organisation, really starting to change hearts and minds and really starting to believe and inspiring a shared vision, enabling others to be part of that. So really reaching out as far as we can, both internally and externally. And some of the comments that we have in our presentation, some of the testimonials and the feedback that we have really start to prove that point and show that that is delivering what we wanted it to do. So I'm just going to hand over now to Sandra, who's going to talk through some examples of how we put that into practice.
Thank you, Linda. So I'm delighted to take you through the next 3 or 4 slides to give you some examples of where we've done some co-production and experience-based co-design work through our strategy. So over the last 18 months, we've worked with our patient volunteers, and actually they've been involved in probably about 40 improvement projects of one kind or another in our work. And we really believe that we've made a systematic cultural shift by allowing the voice of the patient and carer to influence the solutions to the problems that we're trying to solve along the way. And this is one of those projects that we did. So back in May 2021, we co-designed a workshop with staff and patients, and our focus particularly was around flow in the hospital, but discharge home. And how do patients feel about going home from our hospitals? We really want to get the voice of both staff and patients in this arena to see difference. So our aims and objectives of this work was to act on feedback from staff and patients using an appreciative inquiry approach. We wanted to really understand their experience of care and how we might improve that, and take the learning into our improvement programme, and then co-produce our improvement plan with patients and their carers and with staff aligned. So we did this workshop in May. We had, I think, about 73, 75 people in the virtual room. About 10% of those people were patients and or carers. And we talked about the insight and feedback that we'd already got. So these would have been the national inpatient surveys. This would have been our local inpatient surveys and our PALS inquiries, complaints and compliments, a mixture of that insight and feedback that we'd already got. And one of the aspects of our learning from that was that we co-produced a best practice for board round guide. So the primary concern was that we could visualize patients moving through the system. So we really wanted to think about the data quality of when patients were ready to go home, when they needed to be seen by our integrated transfer of care team, etc. So data quality and feedback were at the foremost of our thinking here. And from the output of the production of the best practice for board round guide that we took 33 wards through in our organisation, the output of that was that we did manage to reduce their length of stay. Patients often cited that they were delayed for something or they were waiting for something and didn't really know why. So by increasing and improving the data quality, we managed to reduce that length of stay quite considerably by 1 day. And actually, we've just taken a look at our dashboard this morning, and we have sustained that reduction in the patient's length of stay even now. So next slide, Linda, please. So patient movement was another aspect that actually came out of that workshop. And we believe this was a really, really important piece of work, because this didn't just talk about what happened in the clinical area on the wards or in radiology or in diagnostic areas. This talked about the bit for the patient in between moving from one area to another. So our focus was patient movement, and this from an external review that the organisation had to see, and it really said that we've got no visualisation of how patients moved from one area to another. And the external view, moreover, came to the conclusion that only around 18 or 19% of patient movements happened in the organisation by our portering staff, which meant that our clinical staff on the wards and in the clinical departments were moving staff around the patients, taking them away from them being able to do that hands-on care. So we did a piece of work to have oversight and visualization of that patient movement. We built a dashboard and we produced an electronic process for a request for patient movement to go through directly to our estates and facilities department to hence facilitate them moving the patients as opposed to clinical staff on the wards. The output of that was that we increased non-clinical patient movement from around 18% to 75%. And the value of doing that, as we have on the slide, was that we improved clinical effectiveness. So transfers to and from radiology, for example, meant that we could increase the utilisation of the radiology slots, and therefore we reduced the patient's wait time for their radiology tests significantly, and increased the number of scans in radiology significantly by 120 per week. We increased staff experience in that scenario. So we released almost 15 whole-time equivalent staff time to care on the wards, caring for patients instead of moving patients around the organisation. And we reduced the time it took also to move patients around the organisation in terms of job allocation. That went down from 53 minutes to 15 minutes, and the total job time decreased from 90 minutes to 52 minutes. So we were really proud of that piece of work against the quadruple aim to improve staff experience, definitely patient experience, and clinical effectiveness and use of resources. Next slide.
Reason it's just not moving on. Let me just stop share and share again, because sometimes that just stops it and does it.
Thank you, Linda.
There you go.
Thank you. Always technical hitches and issues. So this third piece of work that I wanted to share with you, which is about do not attempt cardiopulmonary resuscitation in our organisation. We had a fairly lengthy history actually in our organisation where we were not achieving the standards against the for DNA CPR, and the organisation had an external review done of that, really to try and understand what the problem was. And as a consequence of that, from a quality improvement perspective, we were asked to go in there to understand whether using improvement methodology and experience-based co-design methodologies could support an improvement against those standards, which is exactly what happened. So our objectives of doing that was really to enhance the patient and family experience in relation to DNA CPR decisions, and also really defined what changes we need to make as an organisation to meet those Care Quality Commission standards in a sustainable manner. So we did some work with both staff and patients, formed a steering group to really define what our interventions might be to support this programme of work. And I'm mindful that I'm going over on time a little bit, but through that work, the output of that actually was really, really good. In the end, and after 10 months of work, we improved our standards against each and every one of those 7 standards in a sustainable manner for demographics, for having a valid clinical decision. Mental capacity assessment was a huge area that we needed to focus on, and that the patients were informed through the co-production of patient leaflets to really understand what those conversations that needed to take place in order to improve that experience, both from a staff and a patient and carer experience. So delighted that we've managed to sustain that to this day. Thank you.
Thank you, Sandra. And finally, one of the projects that we wanted to share with you was how we have linked in with our doctors in training. Our doctors in training, our registrars and clinical fellows, already go through, as part of their induction, the 5 days CUSA training. So that's the CUSA practitioner training. And we've just added a 6th day in. So it's really about PPI co-production knowledge and how to involve patients and carers in their improvement projects. So they have a really defined clear objectives. So the new knowledge, we expect that the doctors will then be up to date with national thinking about patient and public involvement in quality improvement, and understand why working with people and communities is critical, and have the opportunity to purposely reflect and explore new possibilities as they go through designing their improvement projects. I don't know if audience are aware that chief registrars spend 40% of their week on a QI project. So quite a significant part of their working week will be allocated to improvement work, and we felt it was really important that they too understood the importance of involving patients early and co-production. So just want to hand over now to Hanan, who will just play a little video for us. Thanks, Hanan. I'll just stop sharing.
So what level of CUSA training have you undertaken, and how do you think this has benefited you as a patient?
Hi, I'm Helena and a member of the Patient Partnership Group at NUH, and I participated in the first CUSA fundamentals training that NUH ran for patient and carer representatives. The training helped me to see that successful improvement is a complex activity made easier by a structured approach, a methodology. It showed me why one person's good idea might not translate into a sustainable improvement for all, and that improvement change takes time. It also gave me the confidence to be an equal partner in trust projects.
So tell me about the Do Not Attempt CPR project. So how was this initiated, and what was the aim of the project?
The DNA CPR improvement work came about because the CQC issued a must-do action around improving the completion of DNA CPR forms and documentation of conversations with patients or carers. NUH's medical director commissioned the work to use an improvement methodology within a collaborative approach. So the group comprises governance, divisional representatives, the Improvement and Transformation Department, and patient carer representation.
And were there any specific tools from the CUSA methodologies that you found particularly useful throughout your project?
Yes, all the CUSA tools are being used, but I'll just say a little about 4 of them that I felt particularly relevant to me. Firstly, engaging and understanding others. Through my links with the PPI volunteers, particularly the Patient Partnership Group, we've been able to gather and present a range of patient carer insights and feedback that's informed the project and even steered some elements of it. Secondly, there was creativity and improvement. We patients and carers, we come at things from a different perspective. We're outside the organisation and we use lay language. I think this helps staff to see and respond to things a little differently. Together, though, we've made a huge improvement in the approach to DNA CPR, the patient information leaflet, training packages, and intranet and public website information. And the patient group has its Twitter account, and it can use that to promote the work from a patient carer perspective. Next comes leading for improvement and sustainability of improvement. The collaborative nature of the steering group enables me to facilitate discussions about patient experience, quality, and safety. It's important that a well-administered process is driven not only by a requirement to improve, but also a desire to ensure the patient has the best personal experience of the element of care the process is addressing. And finally, measurement for improvement. Here I see my role as monitoring, encouraging, challenging, appreciating, and celebrating in ways that I hope influence positive behavioural change and helps to ensure good patient experience.
So finally, Helena, what do you think are some of the benefits of having patients involved in our improvement projects at NUH?
Patients and carers often have a different take on what's important and what matters most to us. So we bring our lived experience, a view from outside the organisation, and a desire for NH care to be better integrated and more holistic. Sometimes we also have professional expertise to contribute. I think our presence can lead to interesting discussions and changes of emphasis in projects. For example, we explored the difference in our understanding of the phrase patient experience and the importance of qualitative as well as quantitative change through improvement, even if those qualitative elements can seem harder to measure. Finally, I think creating truly collaborative partnerships of co-design and co-production in projects puts the patient carer voice at the heart of improvement. It's a win-win situation, really, that helps trust provide well-designed services that enables staff to give the best care, which is, after all, what they want to do and what patients and carers hope to receive.
That's great. Thank you, Helena, for sharing your experiences with us. And staff can find out more about how to engage with patients as part of their projects by visiting our intranet pages, which are detailed below.
Thanks, Anhan. I'm not going to go into the last two slides because I think they're really about our next steps. So I will share the slides with everybody. We're happy for the slides to be shared, but really the key message that we wanted to share with you is that how we are now taking all of that learning and taking it to that next step and integrating the co-production into a programme of work. So we're just starting to build our urgent and emergency care programme, which is built up of 3 task forces with 18 interventions that look into improve timely access to emergency services and reduce the risk of delay-related harm. And co-production will be the default in that programme, and we will link our findings and our benefits and impact back to the quadruple aim that Sandra mentioned earlier, that back to that patient experience, the staff experience, those clinical outcomes, quality and safety, and also the better use of resources. So we're really looking forward to sort of commencing that programme of work and taking all the learning that we have to date into that. So thank you. And any questions?
Thank you. Feel welcome to pop your hand up or to put a question into the chat. But I thought I'd kick it off with a couple of questions that I had myself from the presentation that you gave. It was an excellent presentation with a lot of very key examples of the sort of co-production that was going on here. But you talked about how you felt that there was a cultural change within the organization to encourage that this has become quite fundamental now to the organization. What do you think was a key element to enacting that cultural change? Do you have an idea of what that was?
Are you going to answer that, Sandra? Put that one to you.
I'll just take my mute off. Yeah. So I don't mind opening the response from that. So from those examples that I very quickly went through, one of the things that really struck me when we were starting the journey was how open our organisation was to working with patients. And that's not always about working on good news stories. That is about being open and honest about where we've got problems to solve. And that was certainly evident in the Do Not Resuscitation piece of work in particular. I remember one of our steering group meetings that Helena was at, and actually the first time we shared a patient story in connection to resuscitation or not attempting resuscitation, we had a response from a clinician that was really saying, well, we're not really going to, and we don't really want to make changes based on one patient's story. However, after a few more meetings, we approached another patient story, and the response was so very, very different. And that clinician engagement in that second conversation was so much greater, and to my mind really demonstrated that shift of culture to being inclusive, of patients being able to offer something way more than we could ever offer to solve the problem.
Michael, did you have, sorry, go on, Michael, did you have something to add?
Thank you, Hannah. And if I can just sort of add to what Sandra has just said, I mean, I really do believe that successful patient and public involvement has to do with the culture. And when I think about that, I find myself thinking back to my past working life. I mean, I've worked in industries where quality has been critical, in manufacturing where safety has been critical. And in those two areas, we often talk about, you know, a culture of safety and a culture of quality. And what that means is, you know, well, one way of putting it is, if something is a risk is identified, what do you do about it? Do you carry on or do you stop? You know, and I think patient and public involvement is rather somewhat similar to that. It needs to be driven from the top, and we've had two chief executives, our last two chief executives in the trust, who I think have laid fantastic foundations for that. We have a relatively newly appointed chief executive now. I've not had the good fortune of meeting him yet, but my colleagues here have. And all that I'm hearing about him is that he is even more committed, if that is possible, to patient and public involvement than his predecessors were, and that will drive the way through. So that gives me a lot of confidence about how all of this will endure going forward.
Thank you, Michael. Trish, did you have something as well?
Yeah, I just want to add on to that. I think within NUH, there has been a golden thread that's gone through the organisation for many years around PPI and patient involvement. But I think with QI, it's just enhancing that and enhancing that culture. One of the things that we do have, I'm very fortunate as chair of Patient Partnership Group, I do meet with the chief exec and the chair. So there is that culture at the top for patient and public involvement. And I think having that and how it's then disseminated throughout the organisation. And I think this is where the co-production is that big element of this. And it's how we do work in partnership as patients, carers and the public. We have our challenges because, of course, there is the diversity issues and how we get everybody involved. But of course, what we're hoping to do now is how we can actually work with the system, with the patients and the carers and everybody out in the communities and bring that into the organisation. This is something else that's new, something else that's exciting. I think the one thing that I would like to say is being involved with QI right from the beginning, being involved in the strategy shows the true meaning of co-production and how that is developing from that and how we're now developing into a programme. And I think that is the true bit about the organisation and how they want that involvement throughout that programme as well.
Thank you, Trish. There are two questions that Kate has popped into the chat from Cambridge. Who at NUH coordinates and works with the PPG to provide links into projects, ensures that PPG members have all the necessary training and are getting enough support?
I think this might be a Trish question.
Yeah.
Do you want to pick that up, Trish?
Yeah. Well, all volunteers, so all patient representatives, we're NUH volunteers. So we have to have full training with the volunteers. We have CRB checks and everything else. So we have yearly reviews, etc. With the patient partnership group, the head of patient and public involvement or head of patient engagement and experience, as is now, is Katie Moore. and she's been part of the organisation for many years. So I work alongside her as chair of the patient partnership group. So and we have, the PPG have monthly meetings, and we have various people from the trust that come and ask, like estates, etc. As did Sandra and Linda come to PPG, and this is where the PPI Qi all started, but now that has developed as a bit, and you would have seen on one of Linda's slides, it did said that it fed into the PPG and into the patient experience and engagement. So I think it's how we join all of that up together. And I think this is the big bit, and I think it's how PPI and co-production and everything is now going to the next level.
Thanks, Trish.
Thank you, Trish. Kate has another question that was very similar to one that I was also going to ask, is and how do you recruit your patient volunteers and ensure diversity in the group?
I am going to say Trish again, only because this is, you know, one of the things that we talk about as our next challenge. And Michael, do come in, because we've had this open conversation, haven't we, at our PPI Qi group around broadening that out, and really it is one of our challenges, to be fair. So it's a really good question.
When we first started the PPI Qi group, and if there's any projects, we normally go out to the volunteers. So it goes out with a brief, which is really important to have that brief so that everybody understands what's expected of them, and also who's going to support them through the process and everything else. The diversity bit, we do have problems, but of course it's not that you want people to come and sit around the table, because lots of people don't. That's why, as we said, one of our challenges is now that we're going out into the community. So we're going to go to the groups in the community. So the BAME Council that we've got, Shared Governance Council, have given us links into the BAME community. We've got links into the deaf community. We work with our local health watch. We're working with the ICB PPI groups. And this is where we're just expanding that so that we can get that element in, because we are a system now. So we're part of the system. So we use the PPI within the system, we bring that in, and we also feed out into the system.
Thanks, Trish. Did you want to add anything, Michael, to that? Or